PIH, PET, hypertensive diseases in pregnancy, very important chapter. What is mild hypertension? ACOG says when the blood pressure is not beyond 160 over 110, we don't need to use antihypertensives. NICE guidelines say that you have to start antihypertensive once the blood pressure crosses 150 over 100. Right? Now, why is that so? Because labetalol has been shown to decrease the growth of the fetuses. So, intrauterine growth retardation can happen. That is why the role of antihypertensives in mild PIH is controversial. In severe PET, severe PIH, there is no role of outdoor treatment. You have to admit the patient. You have to keep her on blood pressure monitoring, urinary protein monitoring, fetal well-being. Dopplers have to be done. Urine output has to be measured. You have to be careful about impending eclampsia symptoms. And if you see that there are some premonitory symptoms coming, then you have to start seizure prophylaxis. Moreover, antihypertensive treatment has to be started as soon as possible to prevent intracranial hemorrhage. What are the first-line antihypertensives? Labetalol, nifedipine, and IV hydralazine. Labetalol, IV hydralazine, and nifedipine, which is oral, they all have similar efficacies. Dose of labetalol, which is an alpha and beta blocker, is 100 milligrams either twice a day or thrice a day. It can be given as an IV infusion also. Maximum dose per day is 220 milligram. And what are the complications? Bradycardia, hypotension, and it is contraindicated in asthmatic patients. Hydralazine is a vascular smooth muscle relaxant. It can be given intramuscularly or IV infusion. There is no oral dose. Now, the dose is 30 milligram given over 20 minutes. And what are the complications? Tachycardia, headache, hypotension, and palpitations. Nifedipine is given orally, not sublingually. 20 milligram loading dose followed by 10 milligram after 20 minutes. And the side effects are headache and tachycardia. The other second-line antihypertensive drugs which are not commonly used are verapamine, nitroglycerine, nitroprusside, nicardipine, nimodipine, and ketansenin. Nitroprusside is the antihypertensive of choice for refractory hypertension. What can nitroprusside lead to? It can lead to cyanide poisoning. How long do we treat a patient with PIH and PET? It depends upon the gestational age, depends upon the severity of the preeclampsia, the favorability of the cervix, whether she is ready for induction of labor, fetal well-being, and how she is responding to treatment. How do you manage such patients when they are going for a delivery? First of all, the mode of delivery is always vaginal, whether it's a preeclampsia or eclampsia. You can cut down the second stage and reduce the maternal stress by using forceps or vacuum. And in the third stage, we do not give methyl ergometry. In eclampsia, it is obvious we have to prevent the convulsions. We have to stop the convulsions by giving her magnesium sulfate. You have to maintain the airways. You have to give her antihypertensive treatment. You have to make sure that she doesn't fall. The tongue is not falling back and closing the respiratory outlet. What is the drug of choice in hypertensive crisis? It is either IV labetalol or IV hydralazine. Definitive management, if they ask you, in any case of severe PET or eclampsia, is definitely delivery. The mode of delivery, again in eclampsia, is always vaginal. Generally, these patients will end up in spontaneous labor. If they do not go into labor after 24 hours of the convulsion, then you do a cesarean section. What precautions you have to take after delivery? You have to monitor her for at least 48 hours because that is the time when she can have postpartum eclampsia convulsions. You have to make sure that there is a mouth gag and there is oxygen inhalation and suction is done very frequently so that the secretions from the throat can be sucked out. You have to make sure that the leg end or the foot end of the patient is raised so that the postural drainage of the upper respiratory tract is maintained. IV fluids have to be restricted because these patients can land up in pulmonary edema, heart failure, and even kidney dysfunction in the form of anuria and psychosis. When do you perform cesarean section in an eclampsia patient? When there are uncontrolled fits, you are not able to control them, the baby is getting compromised, and if the patient is unconscious and there is no possibility of a vaginal delivery, you go for a cesarean section. What are the causes of maternal death in preeclampsia or eclampsia? Cardiac failure, pulmonary edema, aspiration or septic pneumonia, cerebral hemorrhage, acute renal failure, cardiopulmonary arrest, ARDS, pulmonary embolism, postpartum shock, puerperal shock, puerperal sepsis. What are the causes of fetal death? Baby can also die inside. What are the causes? Prematurity, intrauterine asphyxia due to infarction, retroperitoneal hemorrhage, and uteroplacental spasm, effects of drugs used to control convulsions, especially magnesium sulfate, and trauma during operative delivery. This is all in nutshell you need to know about PIH. Thank you.